Hey, this is Dr. Joseph. Thanks, you guys, for spending, I don't know, 30, 45 minutes or something talking about what's pretty common stuff out there. The webinar thing and the Zoom thing is pretty new to me, but I think we're all getting decent at it with COVID, etc. So again, I appreciate you spending a little bit of time, and hopefully this is helpful information that'll either help something that's hurting or help a friend, or let you decide, when is the right time to come see an orthopedic surgeon, and improve your quality of life if that's what it needed. So I'm going to kind of discuss arthritis, which of course is super common, and tendinitis and various other itises. I looked up the etiology of the phrase itis, which I thought was sort of interesting. It's Greek from the 1500s, and it at first used to imply disease, but then they sort of started to decide that itis meant inflammation. And so everybody's heard of hepatitis, meningitis, all the itises that are out there. And this is no change, meaning that this is the same type of process, but it's to the more structural elements in our body, meaning our joints, which is an arthritis, or a tendon, which is a tendinitis. There's itises of everything, and super common. And it's kind of our catch-all, meaning if we can't figure out that something is torn, or if we can't figure out that something is compressed, or if we can't figure out that something is structurally damaged, then we just jump on the itis. And in medical school, I remember we learned about so many itises of everything. So pancreatitis. And they would say, well, pancreatitis is in 1% of the population. And they'd say, all right, hepatitis, well, that's in 1% of the population. So in medical school, we were all worried because there were 100 of us in medical school. We're like, well, we're all going to get something, some kind of itis. And so the tendinitises and the arthritises of the world are probably some of the better of the itises. And so that's what I'm going to talk about, are the most common ones. In medicine, we talk about horses and we talk about zebras. And so horses are kind of the most common stuff that's out there, and zebras are the sort of interesting ones that are always on the test questions. And so, of course, we're going to talk about the horses today, and that will cover hopefully what's as they say, ailing you, or ailing your friends, or the most common things that hurt. I've had a couple of different itises myself, and so I'm a believer in how much it can get in the way of your life, and it can change the activities you do. And hopefully after this evening, I'll convince you that some of these are really easy to take care of. It's just a matter of acting on them. So hopefully that sort of is a overall understanding. It's a little weird not getting feedback from the crowd of people going, oh yeah, sure. So just do that in your living room if you don't mind. So let's see here. Let me figure out how to go forward. Yeah. So arthritis. So what is arthritis? Everybody throws that word around, and arthritis is basically damage to your joint surface. There's a lot of different causes of arthritis. It's in its simplicity, damage to the slippery cartilage on each side of the joint, and it's kind of wear and tear of the joint, and it's a normal process that comes with anything. So an injury, of course, to the cartilage, or an injury to the bone, or an injury to the structures around it. Let's take a ligament or something that changes the physics, that changes the way things rub in your joint, changes the way the joint moves. That can all accelerate the damage. I kind of think of it as the thinning of the rubber on the tires. So our cartilage, of course, is all born thick and good and normal. And then with life or damage or even genetics, it can just sort of wear out slowly but surely. And obviously it's really common. The arthritis itself can create pain, meaning, can they see the pointer here? No.
Yes.
Yeah. So with this area here, this is the white slippery cartilage that we're talking about. And as it wears down, then it starts to get exposed with cartilage loss and little bone spurs and some joint space that narrows down on the x-rays. And the spurs themselves aren't really sharp. I never like that term because it implies it's like a sharp, pokey guy. And it's not really, it's kind of a blunt thing. But what does hurt is the raw area. And then the raw area of the bone creates a inflammatory process. And the inflammatory process is a lot of the pain generator. And I've always liked that term in orthopedics and in other facets of medicine of what is the pain generator. So what's actually hurting me? Is it the raw bone? Is it the bone on bone? Or is it something else? And a lot of times in orthopedics, be it a tendon or a joint or whatever, it gets inflamed. And the inflammatory process itself is the pain generator. And so if we go after the pain generator, then I don't care what your x-ray looks like or your MRI, as long as the pain is improved, then the function is improved. And that's a lot of what we're after in the beginning treatment of arthritis and tendonitis versus jumping straight to trying to fix it with a surgery. And so that's a nice sort of term to say, well, I always think of that when I see a patient. Well, what is the pain generator? What's causing this pain? Is it compression? Is it inflammation? Is it truly that the surfaces are rubbing on each other and creating a mechanical pain like torn tissue? So that's the basic of kind of what arthritis is. The meniscus in the knee is to try and add cushioning there for the same reason, to sort of slow down the process of this wear and tear. So tendonitis, kind of switching gears to a tendon. Tendons are real strong, of course, ropey things that are very fibrous. And I think of it as a real strong rope that's particularly strong. And over life, over time, of course, just like everything else in our body, gets beat up and worn out a little bit. And not unlike a fan belt, it sort of gets used a lot. And so it kind of wears out a little bit. And when it wears out, and with time, it gets less elastic. And that's one little simple piece of advice. If I'm 50 now, I just turned 50 with my COVID April birthday. And one of the things I continue to remind myself is not to jerk on things. So 1, 2, 3, I'm going to jerk really hard and just make this thing go. Well, that just gets a worse and worse idea the older that we get, because these tendons fail. And the reason they fail is because they're less elastic. And when they get less elastic, we're not 16 anymore, and they just pop and they fail. But separately, they also can get inflamed. And so for, again, a 21-year-old tendon, it's kind of unusual to have a whole bunch of inflammation and irritation around a 21-year-old tendon. But for the rest of us, slowly but surely, it starts to get sort of irritable and inflamed. And so that's what I call it here, the inflammatory condition of the covering or the lining of the tendon. So a lot of times the substance right here is good. It's pretty healthy. It's maybe a little less elastic, a little less stretchy, but the lining, the tenosynovium is the actual word, gets irritated, inflamed, and mad is the way I term it. And then it's trapped in this little sheath, and then there's nowhere for it to swell to, and it hurts. And the lining gets irritated, inflamed. Sometimes it's overused. Sometimes we blame it on trauma. Sometimes we'll blame it on kids or repetitive activity of just keep doing work, or a boss or a wife or a husband or something else. But a lot of times it just happens out of nowhere. Tendonitis can be for no good reason, is very common, but it's common to see patients that are like, well, it may be because of this or maybe because of that. But if there's not a good reason for it, then honestly, it can come out of nowhere. They're very common. Arthritis is more with time, wear and tear, but tendonitis similarly can be with slowly wear and tears. Tendonitis is more episodic, meaning that it's an inflammatory cycle. And I always talk about with patients, all right, I want to do this to break the cycle. And it can be with therapy, it can be with icing, with bracing, it can be with an injection. But the whole idea is let's just break the cycle, because your structural anatomy inside of there with the tendon is often healthy or pretty healthy. And so if we break the inflammatory cycle, then the system works well and the function works well in the as far as the mechanics go. But arthritis is a little different. I kind of call it the gift that keeps on giving. And the reason it keeps on giving is because the surfaces are actually damaged, and it usually just doesn't magically get better. And so we have lots of tricks to clean it up and to cool it off and to inject it. But if it substantially progresses, and that can again be genetic or from trauma or from overuse or all of the above, then a lot of times it actually needs to be fixed. And so usually a tendinitis, we can break the cycle and make it not come back. But arthritis sort of slowly but surely wears out with time. And it's more common that we operate on arthritis than tendinitis. Tendinitis more of an overuse scenario, healthy structures, etc. Arthritis sites, the most common, of course, are knees and hips, and it's because they're weight-bearing joints. And for obvious reasons, they tend to wear out. The nice thing about hips and knees is that there's a lot of bone. There's a lot of bone in your femur, at the bottom of it at the knee or at the top with the hip. And so the replacements do really well. And we, of course, have our own joint replacement doctor. And basically in today's world, if you're going to have a knee replacement or a hip replacement, in general, you go to somebody that does, of course, hundreds of them because they get better at it, like we all do if we do something a lot of times. So, and they do well. Hip replacements and knee replacements, if you look at the numbers, which are really big, they do really well. The smaller a joint gets, interestingly, the worse it does with the replacement. And I think part of that is that when you replace a joint, you're putting in metal or plastic and you're requiring it to stick to bone. And if you don't have a lot of bone to mount that replacement on, then slowly but surely it sort of wears out. And that's why you don't hear about wrist replacements very often or finger joint replacements very often. There's some exceptions, but in general, the smaller the joint, even an ankle joint, is less common, of course, than hips and knees. So we're not jumping to joint replacements when we start talking about elbows or wrists or fingers or things like that. But again, to shout out to the hip replacement and knee replacement world, that fixes problems, and it usually fixes it for a long time, 30 plus years. So the initial treatment on all the arthritises of the world is pretty similar. I think my next slide. Well, the symptoms. What are the symptoms of arthritis? You have stiffness in the joint. A lot of patients describe their stiffness when they sit for a long time or when they don't move the joint for a long time. So that would mean when you wake up in the morning, it's stiff. Going to the bathroom in the morning, it's stiff kind of the first couple of steps. And as you get rolling, then things behave. And so the other analogy would be with arthritis, we want to keep everything moving. So we don't hold arthritis still for very long. We can brace it a little bit, give it a little support, but if we hold it still for a long time, it basically gets stiffer and stiffer. So that's, of course, one of the take-homes is that if you have a little bit of arthritis in a joint, keep it moving. And that goes for our whole bodies too. I mean, we're so lucky up here in the mountains in this population we have, is that everybody's goal is to keep moving. I trained in Louisiana and that wasn't always the goal. And so it's kind of nice to have such a driven population here that regardless of injury or age or life, the goal is always to keep going. And it's nice to have a bunch of friends that all keep going because it makes you say, okay, it's another pretty day. I'm going to go do something. Often achy joints, patients say, well, they're swollen, there's some tightness. The tightness is usually from some fluid. The body will call on the troops, as I call them, kind of call on the troops to try and fix the arthritis, but it has a hard time fixing it, and it makes a swollen joint. So there's an overuse to it. Patients describe, especially in the summer, hiking down or pounding, boom, 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 boom. And boy, the thing swells, it gets more achy. Well, that's the body calling on the troops to try and fix this problem, which is hard to fix with biology. And that's why it gets irritated and inflamed with use. And so not unlike a tire that's got a little of the radial showing through, it still works, but it sort of doesn't work great, and it'll talk to you. Yeah, thanks. Initial treatment for arthritis, everybody knows, icing it. It's an inflammatory process. To heat it up, patients say, well, sometimes I get in the hot tub and it feels good. And that's true. It can make it good, but you should also incorporate some sort of a coolness into it because it's typically an inflammatory process. So a lot of patients say, well, when I warm up the arthritis, it feels better and it moves better, but then it can be a little inflamed. So it's kind of going back and forth a little bit. And I honestly say, well, just listen to your body. And if it feels good to make it warm and it gets moving better, then great. And if it feels better, if you ice it, then great. So that's an easy treatment. Anti-inflammatories, be it Aleve, Advil, Tylenol. A lot of patients say, well, which one's better? Which one's better? Aleve and Advil tend to be a little bit more directed towards anti-inflammatory process. They tend to block the inflammatory cascade. And most patients say that that tends to help them a bit better. It tends to be a little more irritating on the stomach. And so a lot of patients have to take Tylenol. And some patients say, oh, Tylenol actually does feel better than the other two. But I usually have patients kind of start with Advil or Aleve, and then they tend to do better with that. The caution, of course, with Advil and Aleve is with the stomach. And it's well known that if patients take Advil or Aleve and they have stomach pain, then that can lead to an ulcer. And that's a big serious problem. So when any patient says, hey, I've got stomach pain when I take Advil or Aleve with food, that's a big red flag. And we don't mess with that because a bleeding stomach ulcer becomes a big problem. There are medicines that are just as effective that are anti-inflammatories like Celebrex, we've all heard of. And then there's a little bit newer one called Mobic or Meloxicam. Those are a little more expensive. They're prescription, but they're protective on the stomach. They're also easier to take. The last one, Mobic or Meloxicam, is once a day. And if that works for patients, it's pretty easy because it's once a day and protective on the stomach. And so most of us like that. They're not more effective necessarily for the pain relief. And so if Advil doesn't hurt your stomach, then it's fine to take it. But obviously we don't have patients on that for any length of time. There's also the kidney scenario too. So it's usually more episodic. Bracing, that kind of just protects it. There's a lot of different bracing. The formal bracing is with plastic or metal hinges, on a brace or a metal brace that holds the joint still or stabilizes it. And that's really more for an injury, for damaged structures that we hold still and really protect them. Most patients find for arthritis a sleeve, like a knee sleeve or an elbow sleeve or even a little wrist sleeve, kind of contains it and helps it feel more contained and isn't necessarily a structural brace, but it feels better. And patients do that often for activities, say for hiking or skiing or otherwise. And so believe me, if you can just put on a simple sleeve and that keeps it a little warmer and it keeps it contained and it feels better, then by all means do it because that is easy. There's anti-inflammatory creams. Voltaren is this one here. It used to be prescription. Now it is over the counter, which is great. I think they have it at Costco and Walmart, like everything else. And so I think that that's a good choice. It's never harmful. And in general, Voltaren is a good choice for considering an anti-inflammatory that's topical. If patients have an inflammatory process that's really deep and way down inside of a joint, then sometimes it's a little tougher for it to get inside. But especially if it's a tendon or something right at the surface, be it on a tendon here or otherwise, where there's not much meat or not much muscle, then Voltaren is an easy choice to try that. I have patients sort of put it at their bedside and use it, right before they go to bed or in the morning or keep it in their car, however they want to do it. PT is always a good choice. PT helps a lot with conditioning. It helps a lot with the mechanics around your joint. And so it can improve basically the function of your joint by structurally conditioning it. I guess I can also ask our other panelist, Bailey Martin, if he wants to sort of chime in on what's the basic principles of PT for arthritis in the body.
Yeah, I can chime in. Hope you guys can all hear me. Um, the main thing with PT and arthritis is kind of addressing the pain and inflammation, increasing the range of motion, decreasing the stiffness. So we do a lot of manual interventions and use a lot of modalities to help with this. Just joint mobilizations to get the joints loosened up, provide patients with different exercises just to stay moving. We use different modalities such as paraffin, ultrasound, dry needling, just to kind of help decrease the inflammation, get things moving, and then also work a lot on strengthening just to support the joint itself.
And so Bailey, what do you find tends to be the more effective modalities with PT with, let's say, a mild arthritis that's just sort of irritating? What's your first go-to?
If it's something in the hand, smaller joints, I like to use paraffin before doing any manual interventions, just to kind of get that deep heat in around the joints. And sometimes that just makes things more comfortable for just the manual interventions, because some of those can be painful if people are pretty arthritic. If it's so that's kind of the main modality I use for baseball.
And then the paraffin is explain that it's kind of a hot wax.
Yeah, it's a hot wax. So what you do is you kind of dip your hand in, bring it out a few times, and then you allow the wax to kind of harden or dry out on the hand. So it's kind of better than a hot pack, because the heat can get in there around each joint, especially with the joints in the hand being very small. So that
Makes sense. And then what about what is ionophoresis? I've never really understood that one.
So it's using usually use dexamethasone, like an anti-inflammatory, and like a current to help with inflammation, like in the joint, or a lot with tendinitis too. We don't tend to do a ton of Ionto in our clinic, just because everyone needs their own prescription for like the dexamethasone, but definitely another modality that can help decrease the inflammation. So it has.
And then what about sorry to interrupt, how about ultrasound?
Yeah, we use ultrasound quite a bit. I tend to use it more for like a tendinitis issue, especially if someone's really painful, just to kind of help decrease the inflammation and pain in the joint. I'll use that a lot for like lateral epicondylitis in the elbow.
And then other sort of principles as far as like strengthening or conditioning. I know it's a little tricky because I'll have patients, let's just say they have some arthritis under their kneecap, and they're like, well, I want to get my knee strong again. I want to get strong again. But the exercises to sort of strengthen my quads make the kneecap more sensitive. And I always find that a dilemma as far as conditioning the muscles around it, but not ticking it off.
Yeah, and with strengthening too, a lot of just finding exercises that are not painful for the patient. Sometimes the weight-bearing exercises can be painful with arthritis. So finding just things that aren't necessarily weight-bearing, or maybe using like a leg press machine, or just different things like that to kind of strengthen, like for the knee, strengthening the quads and the hamstrings and the hips, just everything around it to support that structure. Another thing that I found that's been nice with knee arthritis is kind of doing like a manual mobilization at the tib or the femoral tib joint, just to kind of help realign the joint while they are strengthening. Say they're doing like a squat or just a sit to stand or something like that, and that can help to take some of that pain away, because you're kind of helping to realign the joint and strengthen in the correct position.
Yeah, that makes a lot of sense. I think what you said too is important, that the pain has to dictate it. I have a lot of patients that, especially from like college athletes or whatever, they're like, well, no pain, no gain. I'm going to push through this. I'm going to push through this painful exercise on my own or otherwise, and see if that's going to help my arthritis or my tendonitis, and it honestly doesn't tend to. It's kind of like poking the bee's nest, and so you have to kind of find a pain-free exercise, which of course bikes are great for that. So for lower leg stuff, specifically knees, that'll keep the joint moving, and it doesn't load it, and it conditions the muscles, and it's usually not painful. And so that's why that and swimming tend to be sort of our take-home exercises. They're not pounding. That cartilage we keep talking about doesn't love to be pounded on, especially if it's irritated. And so to try and condition your body, condition your limb, and condition your joint, but not experiment with a bunch of pain is the right answer. And everybody's different as far as what their limit is as far as that. Any other thoughts from you on advice for exercise patterns?
No, like you said, I think just the kind of or exercises that aren't as much impact, just finding things that aren't as painful, because I agree that most patients think no pain, no gain. And I tell people time and time again that that's not the case in PT, because if you're continuing to do things that are painful, then the joint's just going to continue to hurt. So just kind of dialing back and finding exercises that are pain-free, because there are many different ways to strengthen different muscles. You don't necessarily have to be doing high impact.
Yeah, and that last point is important. The impact thing is just something that our body doesn't love. It doesn't love repetitive impact. It doesn't love high impact. And so to keep everything moving and getting it strong without the impact is kind of one of those lifetime rules. Kind of like I said, not jerking on things. It's that sudden load on our anatomy that it doesn't like. And so, yeah, that's just all right. So let me keep going here. So cortisone injections. Cortisone injections are really common. They basically, I think of it as a potent liquid anti-inflammatory agent. And some people are extremely receptive to it, and some people are a little bit less receptive to it. But most human bodies and most joints and structures all over the body are pretty receptive to corticosteroids. And they basically very quickly block an inflammatory pathway. So I think of it as kind of a fancy Advil or a liquid Advil, where you put 50 of them or 100 of them, and then it's a totally different medicine, but it's the same concept, is that you put that right around the structure that you need it. So let's just say you've got a single tendon inside of a single sheath that's irritated, and it's mad and it's inflamed, and every time you move it, let's take the thumb, which you can't not move, it causes pain. And so if you take Advil and it goes through your stomach and it gets in your bloodstream, then just the tiniest little bit of it maybe, hopefully, gets to that actual local source. And so intuitively, it makes sense that if we can literally put a tiny little splash of 50 of those things right around the area, then even though there's an ouch with the shot, it's extremely effective. And it also doesn't carry all the other sort of risks of stomachs and kidneys and systemic A, B, C, and D and taking a medicine. So that's where in orthopedics, we're real quick to offer injections, because they're usually effective and they're not dangerous. Now, there's always a lot of questions of, well, what if I have a whole bunch of them? And so the things that have shown up is that we do not inject high tensile tendons. So let's take the Achilles tendon, let's take the patellar tendon, let's take the ones that have a lot of load on them. We never inject those. And the reason we don't inject those is because it's been proven that over a lifetime or over a certain amount of years, there may be a higher risk of a rupture. And so you can infer from that and say, okay, well, maybe it's not great to just pound a tendon with a whole bunch of steroids. And that's true. We kind of adopt to that. But that's where we kind of roughly get to about 3 injections. And that's usually over a year. So not everybody's exactly the same on this, but the sort of soft rule in orthopedics is you can inject a structural area, a structural tendon, let's take 3 times in a year. And if that doesn't fix the problem, then we should start looking into other options as far as, is there something damaged with the tendon? Why is the cycle not breaking? Now, arthritis is a little different because arthritis it doesn't really officially damage cartilage. If it damaged cartilage, then we wouldn't offer steroid injections for painful knees or painful anything for arthritis. And so, but that being said, we haven't done experiments on humans where we've done 100 injections in like a month or a week or a year to see what it does. So we're still a little cautious with it, and we kind of use them as playing cards. So again, if patients get a great 6 month of relief from one injection, we all have a bunch of patients that come in and get one injection for a ski season and then an injection for their summer. And they may do that for 5 years and then say, oh, shoot, the injections aren't working anymore. And we start talking about other options. But in general, they're not damaging to your tissue in limited doses. And limited doses would be about 3 injections in one site. So if you have a spine injection, a knee injection, and a wrist injection, that doesn't count. We're talking about one site. And yeah, it can last months to years. I have some patients that will do one injection, even for arthritis, and it'll quiet down an arthritic flare for years and years. And it doesn't change the joint, it doesn't change the cartilage, but it's impressive how well it can work. We put the injection, of course, usually right into the joint if that's what's hurting. The shot's a quick, it's a little bit of pain with an ouch. It's quick though, and there's some numbing agent to try and make that more rewarding at the time, but the result is usually good. And I have a lot of patients that are like, oh my God, I can't believe that I've been dealing with this damn thing for months. I've given up activities, I've given up things I want to do, and it's because it's wearing me out. And then all of a sudden I did a shot and like tomorrow I can lift my grandchild or whatever. We hear that a lot. And so we're pretty quick to offer them because of the upside and the limited downside. Surgery for arthritis. Surgery is kind of limited for arthritis, meaning that, yeah, we can clean up a joint. We can, especially like a knee is sort of the classic one of cleaning up some arthritis. Does it fix your arthritis? No, it does not put rubber on the tires and it does not fix the arthritis. But if you've got loose material, if you've got inflamed, irritated tissue, which is for sure around there, and we've been doing cortisone and it didn't work, and we tried PT and it worked at first, but then it's been less. We've tried other injections like the rooster juice and it keeps on hurting. Then sometimes we'll offer a debridement. And especially if we get an MRI and there's other stuff that can be a pain generator. So if you've got a symptomatic meniscus, if you've got torn tissue on a meniscus, you fix that up, you clean that up, that can be a game changer. But back to our arthritis, all we can do is kind of buff it out and smooth it out a little, but it's not like putting spackling on. I always want to put get some sheetrock spackling and cover that thing up, but we've not found anything that'll stick. And so there's a lot of talk about stem cells and there's a lot of talk about PRP. Sometimes that can help, but it's not going to make new cartilage. It's not going to grow new cartilage. There's other tricks that we can do where we poke little holes in a real arthritic area, ask it to form some fibrous tissue, and that may alleviate the symptoms. So again, it's kind of a cleanup, and the goal is to buy some time. So if we have a 48-year-old that's got some mild to moderate arthritis and it keeps on progressing, we may do a cleanup, and it may buy 5 to 10 years to get them into more their 50s or 60s or 70s. And then they're more for a joint replacement that hopefully will last for their whole life, be it 30 years or more. So, yeah, so that's kind of the idea with that. But the cleanup is still a limited scenario. And I always kind of hang a little crepe if I'm going to do a cleanup for a significantly arthritic knee. A lot of patients say, well, I just want to try one more thing before giving it a knee replacement. That's fine. And if it buys you 2 to 4 years, that's lovely. And then the knee replacement is a commitment, but it also works. Switching to hand arthritis, this joint right here, the base of the thumb, in general, our joints are made like a hinge, right? So the elbow, is a hinge, and the finger joints are a hinge. A lot of the wrist is a little more complicated, of course, but the base of the thumb, literally, let me look at it right there, like the x-ray shows, that joint is different. This joint right here has a ton of motion. So to taking your own thumb, you can make it go up and down. You can make it go side to side. You can just spin it in a circle. And it's designed differently. And by being less constrained and by having more motion, the thing wears out. And it wears out, and it is by far the most common arthritic condition in the hand. In fact, I think I have 3 of these that I'm fixing tomorrow for people that have met their deductibles or are sick of it or whatever. And that is super duper common. We'll see arthritis also in the other joints, but by far the base of the thumb is the one that really talks to people. I had a guy the other day, well, it's been a couple of weeks, and he said, you don't understand, Dr. Joseph. He said, I use my hands every day. And I kind of thought, yeah, most of us do. And so it's true. You can't not use your hand. You can't not use your thumb with life. And that's why it tends to be such a get in the way of everything. But it's also pretty easy to treat. And I'll kind of take you through that. This is called the basal joint, or the first CMC joint. It's inherently unstable, as I was trying to describe, and it wears out. The injections here are amazingly effective. Some patients will have an injection here. They'll have hand pain or thumb pain for years or months or years. One injection, and then I'll see them for a couple of years. Sometimes it's 6 months. Sometimes it's a little less if the arthritis is worse. But it's surprising how effective it is in that area. And that makes me think that it's a real inflamed joint, honestly, if the shot is that effective. But that can be a total game changer. If the arthritis continues and we do 3 shots in a year, and the length of time that it helps gets less and less, then we start bringing up therapy. Bracing the thumb just isn't really great because your thumb's so used and it's cumbersome and people don't like it. And so the surgery to fix it is it's predictable. It's what we do is remove the arthritis. So here it is, the base of the thumb. It's really narrowed. You can see on this particular patient, the joint surface looks pretty good with a bit of space there. And then you look at this one, and it's really narrowed, and it's getting narrow. There's a bone spur there, and it's starting to get wider and starting to turn white and getting arthritis. And so what we do in the surgery is basically we remove this little bone right here, which always sounds crazy to people, or to me too, is, well, wait a minute, and I think I kind of need that bone. But that little bone is expendable, and you can remove that little bone right there. And what we do is take your own soft tissue and we put it in there, and then we protect it for 6 weeks. The way I do the surgery is there's a little anchor that connects here, and it holds this bone up, keeps this space open, put your own soft tissue in there, and then all of a sudden that becomes a soft tissue joint. And again, it's real predictable. It can move exactly the same way because it's like a ball joint, but obviously this arthritic area doesn't hit that one. And so it's a nice surgery. About 6-week recovery, and the statistics are real good when we look at all comers on that, about 95% success rate, which is great. The other thing I often tell patients is it's never too late to do the surgery. So we never are talking patients in, oh, you probably should consider this, or you need to do this surgery. It's not that case. It's your decision, and you once it wears you out so much that you can't, buttons and keys and doorknobs and just life, then that's when it's probably time to consider fixing it. But it's the exact same surgery if the arthritis is terrible or if it's moderate. And so it's never too late to have that fixed. And so I let patients completely tell me what they want to do with that. As I said, with the finger joints, there's a little more limitations. The surgery is not super predictable. It is predictable in the final joint, which is called the DIP, which is this little one at the very end. That one, surgery is predictable, but the reason I kind of am cautious about that is that the surgery to fix that arthritis is to actually glue it together and diffuse it. And so that of course gets rid of all the motion of that little joint. It gets rid of the pain completely, but it also is a trade-off because now you can't move just the little tip there. And there's not a lot of function that little tip is for. Most of the function of our joint is with this one here. And so even if that one's glued together and fused together and the pain is gone, their function is usually surprisingly good. But it's not a real common surgery. It's in patients that it's wearing them out. They've tried injections and they're tired of it. And so we'll glue that together. We don't hardly ever glue this one together, meaning fuse it, because it's so important in the function. And again, there's not great options for fixing this one because the joint replacements are not great in that joint, which is this joint. Same thing with this one here. So 1, 2, 3. This joint replacement doesn't do great. This joint replacement doesn't do great. So we're cautious about that. There's exceptions with rheumatoid patients and other patients that are fairly low demand, and they will do well with that. But we're cautious about a joint replacement real quickly, like we are with knees and hips. So injections are helpful. It'll quiet it down sometimes for years. The topical Voltaren I mentioned, and then oral anti-inflammatories. And as I said, there we're trying to avoid the surgery, but do a fusion every now and then. All right, we'll switch gears off of joints and switch to real common tendons. We talked about it being inflammatory. They live inside a sheath. They're inside of tubes. The lining of these tendons, the tenosynovium. So it's sort of the lining of a joint, but it's the lining of a tendon, the synovium being the common word, that gets inflamed. And then it swells. It's inside of a tight structure, and then it creates a bunch of grief. This happens to be a carpal tunnel, is what this picture is of. So there's a whole bunch of tendons here inside of this carpal tunnel, and there can be inflammation in there. And then here's our one nerve, and that nerve is the one thing that doesn't like to be irritated or smushed. So it gets inflamed, it gets smushed, and then it creates the numbness and tingling that we'll get into in just a minute when I talk more specifically about carpal tunnel syndrome. And as I said, it can be overuse or random or for injury, but it rarely involves actually damage. There's pain with motion of the tendon, and so it can be with motion of your thumb. Of course, it's the tendons that run your thumb. If it's motion of the fingers, then it can be in the inflamed synovium there. It can be on the back of the hand. It can be anywhere around the wrist. There's a lot of different areas that, of course, each one can be inflamed, but they're all real receptive, as I mentioned, to the injections. The most common one is the base of the thumb again, not an arthritis, but a tendinitis. There's 3 tendons that come through here. This only shows 2, but there's actually 3 inside of one tube there, and that one gets really irritated, inflamed, and it's called de Quervain veins, from one of these crusty old school, maybe 1700 doctors that figured it out. That's a real common tenosynovitis, and it's in the base of the thumb. It's also can be in young patients with repetitive activity, like let's take a hairstylist that's over and over again. It's well known in new moms because of lifting babies over and over again, and so that's very common. And it's painful with thumb motion, grip, and grasp, which is, of course, everything, which is life. The brace, if you're going to brace it, it needs to incorporate your thumb. And again, patients don't like thumb braces because it limits your activities. So we're quick to do the first 3 things, ice, brace, and Advil. If that doesn't work, then we try the injection, and it's real predictable. It's at least 90% success rate on the injections there. Rarely with de Quervain veins, about 10%, it'll keep coming back. This little move right here, those are those tendons I was talking about. If you put your thumb in your palm and grip it, and then you go down, and if that lights you up, then they call that pathognomonic, meaning if patients do that without me even touching you, that's what you got. And the reason are these 2 tendons right here. There's actually 3. There's 2 ones underneath that. And these 2 are encased in that inflamed area. This is the surgery to fix it, which is you basically release that tight sheath. It gets rid of the compression, and it's a real predictable surgery. But again, we only have to do that 10% of the time. Usually an injection will make that go away. This one is really common, especially in our real active group here that we're all dealing with. It's tennis elbow. It's not just with tennis, it's with any kind of repetitive gripping and grasping. Some patients don't even have a repetitive scenario and they just get it. I've had it in my own, both of my elbows. I got it from oaring rafts. It was actually a huge river in Idaho, and it was a 10-day trip, and it was big. It was all class 4 and some class 5, and it's not like you can just quit rowing because of the big rapids, the Salmon River. And so just that repetitive gripping and grasping, and I felt it coming on, but again, I couldn't just change my activity. And so I dealt with that for about a year. I had 3 injections in one side and it went away for good. And I had 1 injection in the other and it went away for good. So that's a decent scenario for that. So what is tennis elbow? It's pain on the outside of the elbow. It is made worse by a heavy grip. It's also made worse by wrist extension. So bringing your wrist up, and that's one of the tests we do is we'll hold your wrist, go up against resistance. And if it's like, ow, yeah, that hurts my elbow, that's basically what you have until proven otherwise. It's one of those horses. It's the common one that we see. We see it in weekend warriors, meaning the 40, 50-year-old athlete that goes out on the weekends and does things. And then we see it in repetitive stuff like painters and repetitive activity. And then we just see it in random people that are just comes out of nowhere. If it persists, and you've already tried the normal stuff like Advil ice, stretching, wrist brace, the stretch is like this. You bend your wrist down and you try and stretch like that. And you make your elbow straight like that and you stretch. And sometimes that'll quiet this down. PT can do a good job too. They have a lot of tricks that Bailey was talking about to try and cool off the tendinitis. And so kind of throw the kitchen sink at it. Once patients come to me, they're usually, of course, sick of it. And so I'll say, okay, well, if you want to throw the kitchen sink at it, then let's do bracing, meaning a wrist brace, ice, anti-inflammatories, PT, try and avoid the activities that hurt, and do it all at once. Do it everything at once for 2 weeks, 3 weeks. And if that doesn't work, then we do the shot. And the shot it can be just a total game changer. I have so many patients that are like, oh my God, I've been dealing with this for a year. And you did the shot and I've never even heard from it again. It was gone tomorrow and it never, ever came back. So of course, we're quick to offer the injection when patients are sick of this. And that's, of course, what I did to my own elbow. 90% respond and only 10% of these recur. And it's the same deal where we basically up to 3 injections. We give it at least a year, which is a long time, but a year of treatment and 3 injections. And if that doesn't work, it keeps coming back, we'll usually get an MRI, see if there's torn tissue. And then there's other surgical treatments to try and fix this. But again, that's only 10%. This is the surgery to try and fix that. Basically, you've got muscle. That's what muscle looks like. And then it turns into a white tendon. And then the tendon attaches onto the bone deep under here. And so there's this sort of nasty looking, the words are angiofibrotic or dysplastic kind of junky tissue. The area out here on the outside of the elbow has really poor blood supply, and that's the reason that it doesn't heal. And so it doesn't have a dedicated blood supply. It's got what's called a watershed. So the little blood vessels have to come from other things and then kind of barely make their way up to it. So you get these repetitive micro tears from overuse or otherwise, and then they can't heal themselves because they don't have good blood supply. And then the cycle starts and then it gets inflamed and it's off to the races. And so the 10% that keep coming back, we go find that kind of yellowish nasty and it turns more gray as you get deeper and you actually get rid of it. You excise it, you ellipse it in like an ellipse. Take that out, throw it in the trash can and go down below and there's some bone. And you make that bone bleed on purpose because, again, it's a blood supply deal. So you scrape the bone a little bit to make it bleed, and then you put a little anchor in, and then you sew it to the good neighboring healthy tissue. And that will make this heal typically, but that's a full 6-week deal, and it usually does not come to that. Less than 10% comes to that. And so that's sort of the deal with tennis elbow. Analogously, on the inside or the medial side, here's of course the outside, and on the medial side is the same flavor. It's a tendon attachment that is on the inside of the elbow, and that's just called golfer's elbow. But again, it's not always in golfers. It can be in lots of different patients. It's a little less common than the outside, the tennis elbow, but it's still pretty common. It's the exact same treatment. The only difference there is that that one is exacerbated or made worse when you flex. So you pull down your wrist like that, and you can even feel the little muscles there, of course, on your own body tightened up, and it's tugging on that inside portion. So you lift your wrist up, tugs on the outside, and that's how we differentiate the two. The shots for that are pretty rewarding. Same pain, gripping, grasping, etc. That surgery, I don't love that surgery. It's the same idea, but it's just not quite as predictable as the outside of the elbow. And fortunately, it's a lot less common. So I'm even more hesitant to try and offer a surgery for that. One thing I failed to mention, let's go back to this tennis elbow, is let's say that patients have 3 injections and it's bugging them a lot, but not enough for this, not enough for 6 weeks, not enough to sew it. Do an MRI, it's pretty clean, a little bit of inflamed tissue, very minor tearing. Then there is an in-between procedure where we do an ultrasonic knife that under ultrasound. So we put ultrasound, and then we take this little tiny vibrating knife that squirts clean, sterile water, and we basically go deep into here and we stimulate the area on purpose. And I sort of think of it as stimulating the area, making it bleed, causing the body to say, okay, shoot, now I actually have to do something about this because of what happened here. Something poked the bone, something made it mad, and that can actually fix this. When we do that surgery, we'll often take a little bit of your own blood and spin it down, and then that's PRP, which is a layer of your blood, and put that in there. And basically the whole idea is, again, adding biology. So, and I'm quick to do that here instead of the open surgery too, where I'll just add a little biology there to see if that'll fix it instead of a big recovery, a big surgery. So tendinitis can be anywhere. It can be in all different spots. Of course, I've kind of localized to the more common ones there. Around the wrist itself, it's usually more on the back. It's, as I said, from the tendon rubbing, and rarely the tendon can fray or get damaged, and that can cause a recurrent tendinitis. And then if that's the case, and then we can prove that with an MRI, then we sometimes do surgery to actually repair the tendon. We also get rid of the inflammatory condition, but more importantly, we repair the tendon and then release that sheath that I keep talking about, which is usually the inciting event that your sheath will reform. It's just bigger. Okay, final common conditions. Carpal tunnel syndrome. Carpal tunnel syndrome is super common. Most people know the word, but a lot of people don't understand, well, what is it? It's the median nerve. So the median nerve comes down the middle of your wrist like this diagram. And then right there, it goes through a real tight spot. And that tight spot is the carpal tunnel. And the reason it's tight is because it has those 8 tendons that I showed the picture of a long time ago. There's no space in there. And it gets inflamed, it gets thickened. The tendons don't seem to mind that too bad because they have some room in there, but the nerve acts up. And it can't swell too much because of this little ligament. It's called the transverse carpal ligament, and it's not like a structural ligament like your MCL or your ACL or something that's structural. It's more of sort of a roof, is the way I think of it, as kind of a roof on top of that tunnel. Patients almost always say they have numbness at night. And again, without even touching the patient, if they tell me they have numbness at night, then that is the horse. That is the carpal tunnel syndrome. They often say, well, I got to shake it out. I feel like it doesn't get blood supply, and I shake it out, and it wakes me up at night. The reason it wakes you up at night is because when you're asleep, you'll flex your wrist a little bit. So when you flex your wrist, of course, it'll kink that nerve, and then it kinks it, and it sits there kinked for an hour or 2 hours, and then it decides it doesn't like it because it's already mad because it's compressed, and now it's getting kinked. And then it wakes them up, and they have numbness and tingling. Typically, these 3 fingers, this one, the thumb, index, and the middle. And those are the three that the median nerve supplies, and that's what they feel numbness in. These two here is a separate nerve. That's the ulnar nerve, and it doesn't really live. It lives in a tunnel, but it's not in a tunnel that's shared with all these tendons, and so it's way less common. These three, carpal tunnel all day long. It can be from repetitive activity. The classic scenario a long time ago was the factory worker that's repetitively doing stuff. Patients often want to blame it on sort of repetitive keyboarding, but most of us do a lot of repetitive keyboarding. And so that sometimes can make it mad, but a lot of times it just happens. And there's actually a couple of papers that came out to try and prove that keyboarding doesn't really cause, quote, cause carpal tunnel. And it's kind of a work comp thing because so many patients were filing work comp claims saying that I keyboard at work and that's why I got carpal tunnel. And so now somebody else has to fix it. So it can be exacerbated, meaning made worse, of course, by keyboarding, but it usually doesn't, quote, cause it. And a lot of times it comes out of nowhere and just happens. Let's see, the nighttime brace, that's the first thing we recommend. So a simple Velcro removable brace, you just wear it at night. And if that helps your symptoms, then great. That's an easy solution. Maybe it'll quiet down the nerve, a little bit of Advil, and then we'll also offer an injection. Sometimes if it's just an inflammatory cycle, if it's just inflammation, then the shot can fix it. And I mean, fix it, gone, done, never hear from it again. Classic scenario is pregnant females. So they're in an inflammatory state and they're towards the end of their pregnancy and everything else is going haywire and they get carpal tunnel. And it's like, oh my God, what else is going to happen to me? And they get carpal tunnel, but it's usually purely inflammatory. And so we'll inject that, and a lot of times it may fix that and make it go away for good because it's not a compressive phenomena. And that's how I explain it to patients. All right, maybe, hopefully this is an inflammatory deal and not structural, not compressed. Because if it's smashed, if it's squished in there, then we can do an injection all day long and it'll never fix it. And that's pretty common, these carpal tunnels that have been going on for a long time. These farmers I tend to find that are really heavy duty hands, they're strong, muscular, short hands, and they tend to get carpal tunnel. And these guys just deal with it. They're like, well, whatever, I've had a numb hand for 10 years and still doing fence posts. And they just deal with it because that's the way they're wired. And then all of a sudden we fix it. And then literally that night, they're like, oh my God, it's gone, like completely gone. It's about a 5 to 8 minute surgery. It's very predictable and we love it because it usually works. It works almost every time and it sometimes works immediately. And so it's a total game changer. So if we have patients that we're pretty sure has it, we've tried an injection, it didn't fix it, we're real quick to say, let's fix it. Your nerve does not like to be smushed. It can cause permanent damage if you just watch it forever, meaning weakness. So we're real quick to offer fixing that. And patients are almost always like, yes, I should have done this a while ago. See if I had anything else. That's the gist with carpal tunnel syndrome. Super common, these 3 fingers waking you up at night. If it's early, we inject it. If it's getting worse, sometimes we'll test the nerve. If patients are like, yeah, I kind of want to understand, is my nerve really smashed or not? Do I need to, quote, do something about this? And we can test that nerve and see the conduction velocity, see how fast it goes with little stickers and kind of a creepy nerve test that will test the nerve speed. And if it's smushed, then the answer is unsmush it. Nerves do not like to be smushed, obviously. So, and the surgery is super rewarding. Similarly, but different, is a trigger finger. So a trigger finger is the same idea, meaning it's a tenosynovitis. So by now you guys are tired of hearing that word, but it's the tendon synovium and it's the itis that I started with, but it's down here in the base of your finger. It's almost always painful right there. Patients always complain of a click or a catch. It's usually worse in the morning. It can be painful. And as time goes on, meaning a couple hours, and it gets better and better. And they usually wake up in the morning with it locked. And then they often will have to take their other finger and unlock it. And it's painful and it gets in the way. The shots are surprisingly effective. Usually works overnight. And 90% of them can be fixed with an injection. 10% will recur round and around. And if it keeps on going after a couple of injections, or patients are like, nah, I'm tired of these injections, they're temporary, I want to fix it, then all we do is go release little bitty, it's about a 5-minute little surgery, can be done under local, where you don't have to be asleep for a lot of these small surgeries. And then we just release that pulley, and then it instantly fixed it, meaning that day they're already doing fine. They take care of the skin, 2 to 3 weeks, done. So that's a quick one for us. And we like seeing that because it's easily fixed. So in summary, they're very common. They're complaints of pain. We've got a super healthy, active mountain population, which is just a wonderful group of people to work with. I trained in an inner city New Orleans charity hospital scenario where I got great training on all kind of smashed up A, B, C, and D. But this population is a real treat because everybody is educated, they're motivated, they want to do what's best for them. And it's kind of like, well, how can I help you help yourself? And so I really appreciate living here and working here, as I'm sure most of us do, even in this really weird time. If you're changing your activities because of pain, then come see me and maybe we can turn that around, sometimes real quickly. And sometimes that diagnosis and the solution is easier than you think. So questions for...
Yeah, we've got some questions. So the first question from Mary, if the base thumb joint has been fused, is there a surgery to redo this procedure to allow for more movement?
Yeah, that's a good question. You're right. I get a number of patients that have already had a fusion operation that are really not that happy with it. The reality of it is it's a lot more challenging to undo the fusion and try and put in soft tissue. So basically I can be talked into it if patients are like, look, this is really wearing me out and it's completely debilitating or it's just beating me up. And so there is a surgery basically to take down the fusion, meaning you literally have to remove that glued together, grown together bone, and then you try and put in soft tissue there. But admittedly, that joint hasn't moved typically for many, many years. And so I'm cautious about the expectations of that. I have a couple of other patients that have had the fusion and again, are not super happy with it. The problem with a fusion, any fusion, be it a spine or otherwise, is that if you glue one joint together, then the neighboring joint on each side of it gets more use. So sometimes patients have pain in the neighboring joints because this thing is glued together. And so there's, of course, more demand and more motion in the neighbors. And so sometimes if we do an injection in the neighbors, it'll quiet them down enough that it won't hurt.
All right. So we've also had a lot of questions about taking over-the-counter medications. Like how much should they take and how often is it safe to take it? So Barry asked, when a joint flares up, do you feel it's safe to take an initial dose of 600 megagrams ibuprofen to calm down the inflammation?
Yeah, so each Advil is 200, and so three pills is 600 milligrams of Advil. The box, the label on the thing says that you can take actually 3 times a day. So that's for sure the max. And again, that's a lot of pills and that's really testing your stomach. And so my preference is to do either 2 pills, which is 400, or to do 3 pills. And I kind of start twice a day instead of 3 times a day. Aleve is easier to take. It's twice a day and it's only 2 pills. So if it's kind of a wash, meaning if patients are like, yeah, both of them help me equally, then I'm like, well, you might as well take Aleve. You might as well take naproxen. There's not a statistical difference in the incidence of stomach irritation or kidney problems or ulcers in the stomach from Aleve or Advil, which is ibuprofen versus naproxen. Ibuprofen is Advil and naproxen is Aleve. And the generic, of course, is perfectly normal and fine. Then I'm kind of, if it's the same, you might as well do the simpler one, which is naproxen or Aleve. But to answer your question, I think 3 pills, 600 is fine. And I would kind of start twice a day. And the biggest thing is just listening to your stomach and taking it with a little bit of food.
All right, this question is from Peach. I know I have arthritis in my thumb, but over the last year or so, my thumbs sometimes collapse. And more recently, my left hand fingers sometimes collapse or lock up. What should I do and who should I see?
Yeah, so the locking up or the collapsing can be that the joint has slipped out, it's subluxed. So at the base of the thumb, with a lot of time, slowly but surely, that joint will slide out, and I mean years. And once it slides out, then of course mechanically it's not in the right position, and so then it will feel like it sort of slips out or collapses. The other thing is sometimes when the base of the thumb slides out like that, again, over a lot of time, the neighboring joints have to compensate. So all of a sudden they're having to bend a little funny and bend more in a weird position to try and compensate for the neighbor that's misbehaving. And so for sure, come see us and we can try and determine, is all the problem coming from the base of the thumb, which is what it sounds like, and is that secondarily caused other issues at the neighboring joints?
And thoughts, this is from Sarah, thoughts on diet and effects of food as related to inflammation.
Yeah, good question. So a long time ago, I mean, not that long, but like 10 years ago, 15 years ago, when I was hearing about gluten and inflammation and all that, I kind of was like, yeah, maybe not. I don't really, I'm not positive if gluten really is a thing. It started to show up on menus of gluten-free and you were hearing about it. And then I had a sort of a rash of patients that had this kind of global inflammation. So they'd be like, oh, my ankles hurt, my feet are sore, my wrists are sore, my shoulder gets sore. And what can I do about it? And we tried various things and they kind of worked. And they started cutting out gluten and getting rid of inflammatory foods like gluten. And I don't know if there's a whole bunch of other inflammatory foods, but that seems to be one of the take-home ones. And so I had enough patients tell me that they had an improvement in their overall inflammatory state by gluten. So I think that's worth it. There's probably plenty of other supplements that are out there in the world that are saying that they decrease inflammation. But admittedly, in our science and in our sort of formal medical training, there's not a lot of hard science that says that for sure this type of supplement will decrease inflammation. So going back to like the knees, chondroitin sulfate, glucosamine, those are amino acids. Those are kind of building blocks of cartilage. They're not really anti-inflammatories. They're supplements, but they're not really an anti-inflammatory supplement. So I think gluten is kind of one of the take homes. I don't know if other patients find that, okay, extrapolating it to gout. So if you have patients that have an inflammatory condition with crystals, they find that red meats and shellfish make flares. So you can extrapolate from that and say, okay, maybe too much red meat, too much shellfish can create an inflammatory process. So you can extrapolate from that. But again, there's not real hard science on saying, all right, you need to cut this out of your diet, other than the discussion of wheat or carbohydrates. And again, it's not hard science on the carbohydrates. It's more with the gluten.
All right, so what is dry needling? And I know Bailey wanted to discuss that. So maybe we can throw that over to Bailey and she could talk about dry needling and how it's used for arthritis and tendinitis relief.
Yeah, so dry needling is called dry because there's no injection. It's just the needle. And we use it a lot with the tendinitis. A lot of times you will get trigger points in the muscle, and if the muscle is real tight, that'll be pulling on the tendon a lot. So we can go right into those trigger points in the muscle to help bring blood flow to the area and loosen the muscle up and increase the flexibility. So we use that a lot with the tendinitis. And the other thing I wanted to mention with the tendinitis was the importance of eccentric strengthening. So this is where the muscle is lengthening, and that can help to kind of rearrange the collagen fibers in the tendon. So those are two, but the dry needling we do use a lot with the tendinitis.
All right, thanks so much, Bailey. And we have time for one last question. We've got a lot of questions on stem cell injections, so I'm just going to lump them all together. So what are your thoughts on the use of stem cell injections for tendinitis and arthritis?
Yeah, so that's been a new topic for us, and there's a lot of there's a lot of, I don't even want to call it debate, but there's a lot of discussion about whether stem cells and let's throw PRP. So to get right down to it, the difference in it is a stem cell is kind of a progenitor cell, meaning it's a cell that is more like bone marrow. Let's take bone marrow that's inside of your bone that has a lot of good product. So down in there, it's got a lot of different additives, and without getting into the deep science of it, it's a lot of biology. Let's just call it good biology, but that's inside of your bone, and that's where stem cells kind of live. There's sort of some scam stuff out there where there's these theoretical stem cells that live in fat. And so if you take your fat and then spin down your fat, I'm not sure, at least in our orthopedic world, none of us think that if you take fat cells and spin down fat and then inject it into an arthritic joint, we don't think that's going to do much. And it's kind of in our literature. And if we thought that was as easy as it was just to take some extra fatty tissue, which is all over the place, and spin it down and stick that into a joint and that fixed arthritis, that would just be great if that's as simple as it is. So at least in our orthopedic literature, which is very strict, that's not as easy as it gets. But that being said, there is a lot of potential benefit to adding your own biology to either a tendinitis or a arthritis. Now, I think there's more limitation in arthritis because if the surfaces are worn out and the cartilage is worn out, it's very clear that you can't take stem cells from inside of your bone and stick them inside of a joint and ask it to create cartilage. Again, if it was that easy to take stem cells, take some bone marrow, which isn't that hard, in your hip bone or your pelvis bone, and put it down in a joint and ask it to make cartilage, that would solve the mystery of arthritis. And it's just not that easy. What is sort of poorly understood is what does it do? And maybe it changes the environment inside of that joint. Maybe it changes the inflammatory mediators inside of that joint. Maybe it tries to help whatever is left stay healthy. And that part is sort of the gray area. There's never any harm to it, that's for sure. And that's why they popped up everywhere with patients, with docs that don't even do much arthritis, that are anesthesia docs, or they're whatever, they decide, okay, I'm going to be a stem cell doctor because it's not going to harm anything. That's the truth. But that's where you hear patients, oh, I spent $3,000 per knee and had stem cells injected and it didn't work. And it's like, well, yeah, you have terrible arthritis and it's not going to work that easily. It's just not that simple, or we would all do it. But the other side of the coin is if the stem cells help rebuild what it can and helps change the environment inside of that knee or inside of that joint and makes it less painful, or even gives it 5 to 10 years, then absolutely it's worth trying. It's not covered by insurance, which is of course kind of a mess. But part of that is that there's not the hard science to prove it. So that's the stem cell world in general. A lot of patients, a lot of docs, a lot of orthopedists will use it as an adjunct. So let's say they go repair a rotator cuff, or they go repair a meniscus, or they go put in an ACL, or go put in some structure that you're asking to grow. Well, then why not put some more biology inside of there? I think that's really practical. It may help the entire process, but it's sort of poorly understood of exactly how does the stem cell work. Now, separately, PRP is a little simpler, meaning we don't have to get any bone marrow from you. You give some blood, we spin it down, we take one layer, the plasma-rich platelet layer, and you take that, you put it into a separate syringe, and you put it into the area that is mad, put it into the area that is inflamed, put it into the area that has some chronic tearing. It adds your good biology, and there's some pretty good science to say that that can help you. So let's go back to that tennis elbow scenario where I'm doing a surgery on that. And I know it's a poor blood supply area. I'm like, why not? Let's put some of your own biology in there. in general, with most areas that have good blood supply, it's not needed. And so if we fix your clavicle, if we fix your broken wrist, if we fix your tibial plateau, if we fix these real predictable things, then it's not going to speed up healing because they have great biology. And so in patients that are like, all right, well, I don't necessarily want to do a surgery, and I've tried the cortisone, and I'm willing to spend some extra money, even if insurance won't cover it, then absolutely, it's a good in-between chance of, okay, maybe it just needs a little boost of biology.
All right, so that's going to conclude our presentation today. I want to thank everyone so much for joining us tonight. I also want to thank Bailey Martin for adding her expertise to this presentation. And if anyone has any other questions or wants to make an appointment with Dr. Joseph, his contact information is up on the screen. So thank you all so much and have a wonderful rest of your night.
Thank you.